In this video, we will review posterior capsular opacifications, commonly abbreviated as PCO. We'll begin with a bit of background information and epidemiology, and then move on to the pathophysiology, risk factors, clinical presentation, diagnosis, and finally management of PCOs. So posterior capsular opacifications are the most common complication after cataract surgery. The typical scenario is a patient who develops a cataract, undergoes cataract surgery, experiences visual improvement, and then a few months to years later notes a recurrence of the cataract symptoms, things like blurry vision, glare, and halos. That patient has developed a PCO, and for that reason, PCOs are often referred to as secondary or after cataracts. In fact, the patient does not have a cataract in the traditional sense, since the patient has had their lens removed and an intraocular lens in place. A PCO occurs when residual lens epithelial cells migrate, proliferate, and differentiate on the posterior capsule, and it's this regrowth of cells that blocks incoming light and clouds vision. So in patients, PCOs are inevitable. Some studies report that anywhere from 20% to 50% of patients will develop a PCO within 2 to 5 years of cataract surgery. In children, that rate is even higher, and it's estimated that up to 100% of children and infants after cataract surgery will go on to develop a PCO. So the pathophysiology of a posterior capsular opacification is multifactorial, but it is thought to involve the abnormal proliferation of cells. So recall that in cataract surgery, a circular incision is made through the anterior capsule. This is called a capsulorhexis, and this creates a hole through which the cortex and the nucleus can undergo phacoemulsification and then be aspirated out. Now the posterior capsule is left in place, and then the artificial IOL is then placed into the capsule. The problem is that the layer of cells directly beneath the anterior capsule are the lens epithelial cells, and these are very mitotically active. And so after cataract removal, these epithelial cells can migrate towards the posterior capsule, and they can proliferate and undergo abnormal differentiation. So many growth factors have been implicated in this process, and it is these lens epithelial cells that can obstruct vision. So risk factors for PCOs include younger age, diabetes, uveitis, myotonic dystrophy, retinitis pigmentosa, as well as a history of a traumatic cataract. So PCOs can present very similarly to any other cataract, typically with decreased vision or blurred vision. Often patients will complain of difficulty with reading. Patients might experience glare or halo around lights, as you can see here. Some patients will also report some light sensitivity as well as reduced contrast sensitivity. And colors can also appear more dull and less vivid. So diagnosis is fairly simple and involves slit lamp examination. So here you see two examples of posterior capsular opacifications. Often an ophthalmologist will know to look for a PCO when a patient presents with blurry vision or visual acuity decline after cataract extraction. A finding that can be seen in PCOs are Elshnig pearls, which are seen here, and these are grape-like structures that form from residual lens epithelial cells that migrate to the posterior capsule. Now, when mild, these may not pose any significant problems, but over time these cells can proliferate and migrate to the central visual axis and obstruct vision. Now note that there is this central clearing here without any Elshnig pearls. In fact, there is no posterior capsule, and that's because this particular eye has undergone treatment for PCO with a YAG posterior capsulotomy. So a posterior capsulotomy or a YAG capsulotomy, so called because it uses the YAG laser, is a very quick procedure that essentially serves to create a hole in the posterior capsule, allowing light to shine through unimpeded. So this on the left is an example of a pseudophakic eye that has undergone a YAG capsulotomy. You can see here the borders of the YAG laser, and note that these opacifications in the periphery are not symptomatic because they are not in the central visual axis.